physiological response, not only pupils, but chest discomfort, tachycardia, trembling, those kind of things. So the question at the bottom there on your lecture guide is anxiety bad? Well, maybe yes, maybe no. It depends on how much anxiety you actually have there. It's a warning sign that the person needs to assess and evaluate both their self and their situation. Can you have too much stress, not enough sleep? Can you be harboring too many negative feelings? Do you need to take a break? Do you need to ask for help? So the problem that we've come into is when people can't self-assess themselves. You know, if you're unable to look at yourself and say, I'm not getting enough sleep because I'm so worried about this. I'm so worried about going into my job because they're so threatening to me, etc. If you can't step back and self-assess, then we reach problems with anxiety that kind of keeps you from doing your everyday functioning. So the book will talk about norepinephrine, dopamine, and serotonin, and you need a good mix of all three of those. Norepinephrine helps you with alertness and gives you energy to function throughout the day. Dopamine, if you have the right amount, allows you to have motivation, pleasure, etc. It helps with your mood. Serotonin can help with obsessions and compulsions. So you need a good mix of all three of these to have a motivating or a slightly anxious, but not something that interferes with everyday life. So we need these in the right amount. Cycles of anxiety that your book talks about, where there's some type of trigger, there's something that causes the anxiety. You have thoughts that are negative or fearful. The anxiety, you either have anxiety or a panic response, and we'll talk about panic responses in a little bit. And then beliefs. The beliefs are formed or perpetuate the cycle. A trigger happens again, and you continue to have those. And unless you can deal with what the trigger is in a positive way or a non-fearful way, the cycle of anxiety continues just to keep going around. So if you look at the exam, the trigger might be your nursing exam tomorrow. The thought is, I'm going to fail the exam. The anxiety is you have increased anxiety over that. And the belief is that I can't pass the exam. Okay, so if you keep perpetuating that, you never get out of that cycle. Okay? And hopefully you don't think this. I mean, the trigger, I'm sure you're anxious about your nursing exam tomorrow. I'm sure some of you have thoughts of, I'm not going to be successful. I probably should say successful instead of fail. That usually makes more anxiety. But, you know, you step back when you have those thoughts and you think, I've studied for the past 6 days. I've done all I can do. I'll take a deep breath and I'll try my best. And that's all that we ask at times in life, is that you just try your best. Will there be times when you're unsuccessful and you don't do your best? Sure there is. Then that's when, instead of having increased anxiety, we're going to step back. We're going to see why you were not maybe as successful as you wanted to be, deal with the problem, and then go on, instead of it perpetuating number 4 over and over and over again. Okay? How do we work then with patients that are anxious? Well, there has to be some self-awareness of your own anxiety level. Somebody that is truly highly anxiety-ridden or has a panic disorder, we would not want a hyper nurse to go in and take care of them, okay? Because hyperactivity or anxiety feeds anxiety. Assessment of the person's anxiety level. Where are they in their piece of anxiety? We said when somebody is anxious, you need to use short, simple, easy to understand sentences. We need to lower the person's anxiety to a moderate or mild level before we can proceed. So I think one of your questions before was, you know, deep detailed information, and we said patients with a lot of anxiety or stress cannot handle detail. They need simple instructions on what they need to do next. So a low, calm, soothing voice. If they're in a severe or a panic level, we need to think about safety for them. And then number 7, maybe short-term use of anxiolytics, Xanax, Valium, Librium, Klonopin, something like that. And we usually try to limit that to maybe a 4 to 6 week window, because what we're really trying to get at here, we don't want them to be on lifelong anxiety medications if they don't need to. What's causing the anxiety? What can we do to change the thought process so that they don't get to this severe or panic level where they really can't function and interact with you and have a good understanding? So we want to do short term, 4 to 6 weeks. It'll take a little bit, their anxiety medications before, a day or so before they get lower levels. But we want to make sure that we don't get to that severe and panic level with these patients, and we don't want them to be on lifelong anti-anxiety medications unless they absolutely need to be. Treatment for our anxiety patients then would be combinations, medications, and therapy. We talked about the medications would be anxiolytics. Maybe depression is part of this now because their anxiety has went on for such a long time. So we could do some type of antidepressant therapy. Again, we want to try to do short term. We don't want to try to keep patients on drugs any longer than we need to. There are side effects to taking these medications, and we really, if we can get them off through therapy, we would do that. Cognitive behavioral therapy is another thing that we can utilize. It teaches the patient different ways to think, behave, how to react to situations, and we do that through positive reframing, turning negative messages into positive ones, decatastrophizing situations. We make them more realistic. Is it likely that this will happen? Could you survive this? Redirecting, making it more of a realistic statement for the client. And then assertiveness training, learn to negotiate interpersonal situations. So we teach them to use I statements. I can, I will. Instead of I don't know, there's no way, we turn it into a more positive behavior for them. And then 226, we touch on benzodiazepines a lot. There are some non-benzodiazepines, Buspar, Miltown, that they can take, but pretty much when we're looking at anxiolytic drugs, I think you're familiar with those. We have a lot of patients probably that you're caring for throughout, whether you're mental health or out on a med-surg floor, that patients are taking. So I think you're probably pretty familiar with a lot of those. I look at this slide and I think, easy for you to say. Do you have that family person that's like, just let it go, just relax? And you're thinking, you have no idea what you're talking about. Especially as you're trying to study for a nursing exam. You might have a spouse or a mother or a father that's like, just take time away, go do something. And you're like, there's no way I can go do that. I have to study for this or I will not be successful. So I look at these and I think if you could take them to heart, they are helpful. It is hard to let go and step back and not be anxious about certain things in your life. So I get that. I look at these Post-its and it looks like they're crumbled, like maybe the person crumbled them up and threw them away and thought, there's no way I can do this, and then they had a second thought, they took it back out, and then they put it back on the board and thought, maybe I can do these. there, but I understand stress is a difficult thing and anxiety to deal with at times. Okay. All right, our types of anxiety disorders, incidence, 1 in 4 adults is affected. I don't know that I have that, but it is in your notes. And then the onset, it is more prevalent in women, people usually younger than 45. Oftentimes they're divorced or separated, or they have lower socioeconomic status. If you think about, people younger than 45, sometimes I don't think they've maybe lived enough life to have good coping skills yet. Women, I can see that in the divorced or separated folks, your support person is gone, or there might be a lot of disgruntledness between your ex, especially if you're co-parenting, those kind of things. Lower socioeconomic, not only do you have everyday life, but you have economics come into that. Do you have a car to get places? Do you have transportation? If you don't have enough money for daycare, those kind of things, how do you get to your job, especially if you're little kids? So I can see where lower socioeconomic folks have added everyday stressors to their anxieties. Onset for them is variable. They don't really have a certain situation that causes it, certain things, so it can be variable. So the first one we're going to look at is panic disorder, and panic disorder is the most common type of anxiety disorder that your book talks about. The definition are there discrete episodes of panic that last anywhere from 15 to 30 minutes. They're rapid and they're intense and they escalate in anxiety. So you can see the panic cycle on the slide there. We have anxiety, you have a panic attack, you're fearful, you'll have another one. You have more anxiety, it causes another attack, more fear, anxiety, panic attack. It just keeps cycles. Panic disorders tend to peak in late adolescence to mid-30s. I would like, and I don't know this for a fact, but I wonder, and I'm pretty sure that our current situation has probably added to a lot of people's panic. My hairdresser and I, of course, if you go to the hairdresser, men you probably don't, you're in and out of the barber shop very quickly, or somebody's cutting your hair. But us ladies, a lot of times like to go and be pampered and you like your hair done. But you tend to talk about all kinds of things with your hairdresser because you only see them once every 6 to 12 weeks or every 1 to 3 months or something like that. And she was saying how she never thought she had a lot of high anxiety, but when you had to do all the masking and stuff and in stores, she said she found herself really almost having panic disorders when she would be in line to check out because people would get too close to her. And she's like, you need to maintain the 6. She said, I never said that to anybody because she said, I saw radical people that said that to other people in front or in back of them. But she said, when I was standing there, a couple of times she had to leave and go out and sit in the car, and her daughter's of age, like 20, she would leave her credit card, and she's like, I just can't stand here anymore. I've got to go out to the car and get away from it. So I wonder if our current situation has led to more people having some panic situations when they're put in certain situations. Not all the time in their life, but when they're put in an area that triggers them, that more people aren't suffering from anxiety and panic disorders due to our pandemic type situation. So things that we have in our piece with panic disorders is that we have to have certain situations. So in the nursing process, we do assessment. So they have to have 4 or more of these in order to be classified as a panic disorder. So some of the things that they have will be palpitations. So they might have sweating in relationship to that. They may have